Thank you very much. I would start by thanking a lot the organizing committee for inviting me to give this talk, and Sanofi Aventis for organizing this very interesting meeting. Having said that, I will say that last night I didn't sleep very well after Norman Woolmark talk, because, you know, I have children and they are still doing studies, so what will I do in the future to support them? Is there no future for pathologists? So I'm going to show you now that, yes, there is still some hope for us, I hope. So the classical prognosis and predictive factors that we use in breast cancer, we have already dealing with fact a lot, but I will come back on some of the parameters that we use, and first of all on the TNM parameters. Okay, so the treatment decision are based on size, but in France, the last survey that we have is 62% of T1, so very small tumors. Node involvement is a major prognostic factor, but also 65 node negative tumors in France since 2007. And we have these sentinel lymph node studies, and we have more and more micrometastases or isolated tumor cells, and we don't always know what to do with those information. On the opposite, so the TNM is decreasing a lot, and we don't know if this information is important. And as Nadia said, it's not because you are node negative that you are at good prognosis. And we had a lot of molecular assays now available, well, at least now one, because one has been dismissed, but they don't detect micrometastasis, so the micrometastasis are isolated tumor cells. So here, once again, the pathologist will be important to look at the isolated tumor cells on the slides and tell to the clinicians that we have those tumors. And we know that with these TNM parameters, we are misclassifying patients in almost 30 to 40% of the cases. In fact, when we look at the tumor, what we look with the TNM parameters is how long the tumor has been there. This is the staging. But with the mass breast screening, we have now to look more deeply into the intrinsic parameters, the nature of the tumor, and the biology. And here, I can tell you, the pathologist can help. So, first of all, with the parameters of histological differentiation, and those parameters are tumor type and histological grade. We can classify tumor with their histological types in different prognosis categories. And some tumors are per se of excellent prognosis, like mucinous tumor, like tubular tumor, for instance. Some tumors have good prognosis, others we know have an average prognosis, and in those tumors we have the classical lobular tumors. Usually luminal A tumors, but average prognosis. And we have the poor prognosis category with the high-grade ductal, but also with the variant of lobular tumors, very aggressive tumors, and also, for instance, the macropapillary. So here, you need the pathologist to tell you what kind of tumor do you have. The Peru and Sorley intrinsic classification has put some new light in our understanding of breast cancer. In these first studies, they only look at ductal carcinoma, and they have subclassified the tumors in different categories, which can be translated rather easily, even if it's a little not completely precise, and, but by immunohistochemistry using our basic parameters, ER and PR, HER2, Ki67 or grade, we will come back later, and have a first classification, a raw classification of this intrinsic classification, with the luminal A being with a low proliferation, the luminal B high proliferation, and also ER and PR positive, the HER2 group, the basal-like being triple negative and having the high molecular weight cytokeratin, EGFR, or other biomarkers. But we have now some changes with the luminal B is also with the HER2 positive, ER and PR positive is in this group, and they share a lot of genetic similarities. And we have also the Claudine Low group, which is a triple negative group with some expression very close to stem cells, and also linked to an histopathological subtype, which is a metaplasic or sarcoma-like breast cancer. So we can help in this classification. So these histopathological subtypes are easy to recognize. Some are clearly good. So we need to tell that to you. Some are of very intrinsic poor prognosis, and sophisticated tests are not required. We have very consistent results. Maybe the only exception is the medullary carcinoma, which really requires a second opinion from a breast pathologist. But those subtypes are not taken into account by the intrinsic classification, and they don't impact upon treatment option. You treat a lobular carcinoma exactly the same way as a ductal carcinoma, and we know that the biology is completely different. Another point is that when you look at the basal category, we know that we have different we have different tumors. So this classification has a prognosis and a predictive value, but does it bring new information compared to the WHO classification with ER, PR, and the HER2 status? And is running a gene expression profile assay for a luminal tip breast cancer, luminal A, more accurate or more cost-effective than histopathology and immunohistochemical staining? And as we have as has been already mentioned this morning, we know that the 4 immunohistochemistry panel gave the same result as the Oncotype DX in the TransAttack study. And the basal-like group encompasses a large variety of tumors. And within those tumors, you have very good prognosis tumors, like the adenoid cystic carcinoma, the low-grade squamous carcinoma. Those tumors have an intrinsic good prognosis, and they are in the basal-like group. So here again, you need to have histotyping of the tumor, and this is done by pathologists. We have a recent tool by qPCR, so can be done on paraffin-embedded tissue, the PAM, that can look and reproduce the intrinsic classification with an easier and a cheaper tool. So maybe we can also compare this tool to the immunohistochemistry. We have discussed already a lot on SBR. I want first to start that when you have tumor grading, looking at the different places in the world, some of the pathologists give you only nuclear grading. Other pathologists give you the classical SBR grading. What is recommended in Europe is to use a modified SBR grading, modified by Elston and Ellis. And this is a standardization of tumor grading. This gives to the pathologist rules in interpretation and rules for the mitotic count. So this is much more reproducible than the classical SBR grade. 50 to 60% of the tumor are in the grade 2 category, and this is really a problem. But in France, in the 80s, Dr. Viviane Ledoussal has produced the MSBR grade, and it was a way to work on the grade 2. We were only taking 2 parameters of a grade, proliferation and anisokaryosis, and we were stratifying, and we still use this MSBR grade in France, stratifying grade 2 in high risk grade 2 or low risk grade 2. Unfortunately, we have never had the possibility to compare this way of scoring with the molecular grade, but it could be interesting. So, as I said, I think that grade can be standardized, and pathologists are trained and can be trained better for grading. And it's still very important to have grade, for instance, for neoadjuvant. And this grade, one of the major parameters is proliferation. And a grade 1 tumor cannot have a high proliferation. It's mathematically impossible. And a high-grade tumor mathematically has a high proliferation. But in some places, it can be poorly reproducible, especially if you don't use the modified SBR. And these grade 2 tumors are heterogeneous. So who is better to look at heterogeneity? Is it a pathologist being able to screen all the slides and looking at the different parts of the tumor, or is it a molecular test mixing all the cells together with the stroma and giving a result? I think, my opinion, pathologists may be better for that. And as I said, we don't have any direct comparison of this way of stratifying grade 2 with genomic grade. So now let's move to predictive biomarkers and hormonal receptors. So everybody agreed that it's important to look at ER and PR in breast cancer, and immunohistochemistry is actually the reference test. It identifies the cells in the nuclei of the tumor cells having the signal, and it's cost-effective. But we really have quality assurance issues. But if we look at the history of the quality control test, you can EQUAS for United Kingdom and Europe, AFACAP in France. If we look at the first run of quality assurance test back in the 80s, middle of the 80s, beginning of the 90s, the results were like 50 people didn't pass the test, especially for the low expressor. But now the results are that only 10 to 15, okay, it's a lot, but only 10 to 15 pathologists don't have good results, and it's especially for the low-level positivity. The high-level positivity, usually the quality assurance results are very good. But we also have problems that the cutoff values are not standardized. 1% can be positive in the United States. In France, it's 10% positivity. So we don't speak the same language. And we also have problems with the assays, and we had problems with progesterone receptor 2 or 3 years ago. Now it's good, but it can change. So we have to, on everyday basis, check if the assays are good also. So this is a lot of training for the pathologist. And we already have also discussed that. Is it really accurate? It's okay to select the patient, but it's not really predictive in terms of hormonal sensitivity. HER2, it's the same. HER2 now, almost everyone is using immunohistochemistry as the screening tool and in situ hybridization for the 2+ cases. It's rather cost-effective, and the patient identification for HER2-targeted treatment is rather standardized. But we also have quality assurance issues also for this 2+ intermediate category. And the main problem is that we have a HER2 receptor in all our cells. So doing immunohistochemistry, we have to have an assay which is only detecting the overexpressing. So that's why we can have false positive or false negative depending on the assay. The cutoff value are not stabilized yet, and we had a recent change in 2007 with the new ASCO guidelines recommendation for HER2, and this cutoff was not changed because it was better to predict response. It was changed because it was better for the correlation between immunohistochemistry and FISH. So we still have a lot of work to do for that. We also can have problem with antibody batches, and it's only selecting patients, but it's not accurate as a predictive factor. We have molecular tests available to dose ER, PR, and HER2. It's Oncotype DX, and it's target print on fresh tissue. They correlate relatively well to ER, PR, and HER2 status, but it's mRNA, it's not protein. So mRNA is okay, in my opinion, for HER2, but it's not the same with the protein with ER and PR because of methylation or other post-transcriptional modification. And they are very expensive for the moment, so we cannot afford, at least in many countries, those tests. And as I already mentioned, ER, PR, and HER2 are not, they're helping the identification, but they will not tell you what will be the responders. So we still need more information, and here molecular tests, maybe other tests than the one we have already, really predictive tests will help us in this. We have then a second generation of biomarkers, and only one has a level of expression 1 is UPA-PI1. It requires fresh tissue, but it can be performed on tumor biopsy, and I think it's a very interesting one, and we cannot do it by immunohistochemistry. There is absolutely no concordance. It's really biochemistry. Micrometastatic disease, especially in the bone marrow, is a very strong prognosis factor for a node-negative population. But it's very difficult to implement in the clinical practice to have these bone marrow samples. And Ki67 or proliferation markers are prognostic and predictive factors, but still some caveats. So just to come back to UPA-PI1, and it's really a clear prognosis factor. We still have to decide that we do this test, and it's cheap when you compare to the molecular test. This is a meta-analysis by Brown on 5,000 patients looking at bone marrow micrometastasis, very strong prognosis factor. And this is the Ki67 and another way to look at the PAX-01 data, and here Ki67 was predictive of response to taxane-based regimen. But we have problems. What is the good cutoff? What is the good cutoff for endocrine sensitivity, for chemo sensitivity? We still have to work, and as Beppe Viale mentioned earlier, we have this working group starting reflection soon on standardization of Ki67. I will finish my talk with my opinion and my experience, because I have tested, and I have tested the three signature. First of all, the MapQuant, the Genomic Grade. It's a 97 gene test with a very precise evaluation of proliferation for SBR grade 2 especially, not positive or not negative. It requires frozen samples, and it has a really clear prognosis value, and we don't have published evaluation, but we have seen evaluation in many congress on predictive value. Showing back this slide, really, with this genomic grade, you can see that grade 2 split clearly in two categories, high and low grade. But probably that I really want to know if with our histopathological tools, maybe we can do the same with the modified by Le Dussal SBR grade. Looking at mammaprint, the Amsterdam signature, 70 gene signature, it's a dichotomic response, good or bad prognosis, and it's suitable, as we said already, for not negative and 1, 2, 3 not positive cases. It's prognosis and predictive, and surprisingly, among the 70 genes, we don't have ER, PR, or HER2. But we will have the answer of the accuracy of this test in the MINDAG trial. The Oncotype DX, we have a very complete talk on Oncotype DX yesterday, so I don't want to go back too much in this, but just to say that it's suitable on frozen, on paraffin-embedded formalin-fixed tissue. I have a concern about the cutoff. Nadia showed us for our trial the recurrence score 11. In some of the data, especially for chemotherapy, the recurrence score was, the cutoff for low was 18. And yesterday we also saw the cutoff was 15. So it looks like ER and PR or HER2 with the same problems of cutoff. When we look at those different tests, we see that basically we have the same information, except for mammaprint for ER, PR, and HER2. We have the proliferation in common, and we can look at the proliferation also with the classical test. So we have some issues with the molecular signature. First of all, we have a minimal overlap of a gene assessed in the different profile, only one gene common to mammaprint and Oncotype DX. We have no standardization of the technique like specimen selection, issue of reliability, reproducibility, and inter-laboratory testing because they are centralized. And for mammaprint and mapquant, we require fresh tissue. But it's not because you have fresh tissue that everything will go well, because there is a problem to time, not to fixation, but time to freeze. And also the tumor cellularity is really an issue for that, and some tests cannot be done because of poor cellularity. Oncotype DX is adapted to formalin-fixed paraffin-embedded tissue, but is it reliable with other fixative? And we have plenty of other fixative used now in the world, especially fixative without formalin. And is it reliable in case of poor fixation? If the specimen has stayed too long in the fixative, we don't have answers with that. So we don't have yet the results of the clinical trials to be sure that it's a level 1. What is the cost-benefit ratio? The studies conducted for mammaprint and Oncotype DX have been driven more or less by the company, so they show the benefit ratio, but it's still questionable. We are conducting an economic study for Oncotype DX with 600 patients. And the problem of reimbursement, Oncotype is only reimbursement in the US and mammaprint is only reimbursement in the Netherlands. But in the other country, the patient have to pay and it's 2,000 euros. And which tests were for which patient? Martin Picard showed us this slide this morning. I can comment it rather differently. On the basal-like group, all the tumors are, almost all the tumors are high grade. So it's normal to have them in the high proliferation part. Same for the HER2. Majority of the HER2 tumors are grade 3, some of them are grade 2, and almost none are grade 1. So it's really within the luminal category that it's interesting, but here we have grade and Ki67 to make the distinction. So clearly for those molecular tests, but it's, you know, we have already said that, it's the ER positive, not negative population, which is the target and the interesting category. So in conclusion, the three commercially genomic assays I just showed you for prediction of clinical outcome, none of those assays have reached highest level of evidence, but you have heard a lot of them because we have companies behind. And UPRPI1 has a level of evidence 1, and no one is making advertisement for UPRPI1. They identify high-risk patients when they are in the high-risk category with relative endocrine resistance, relative chemosensitivity. But we can say that with the grade, with the proliferation and everything. So is pathology still cornerstone in the management of breast cancer? I will answer yes. Can we clone Beppe Viale? It would be very, very nice, probably, yes, I'd like to. But unfortunately, no. So I think that accurate pathology testing is essential for individual patient selection and treatment design. And as Nadia Arbeck said yesterday, and I really appreciate this comment, I think that resources should be dedicated to support training and quality assurance program. Because quality assurance is very expensive, and we don't have the resources to do that. training also is important, and to understand the importance of fixation, time to fixation, but it's also, we have to train also the surgeons not to rush us to give the results the following day of surgery, because they don't treat the patient within the 3 first weeks. So we have time to give ER, PR, and HER2. It's very important to have a good tissue. ER, PR, and Ki67 and HER2 help in the identification of the population, but probably the most important test will be the test to predict specific drug sensitivity or resistance. And the molecular test could add accurate information, but we wait for true predictive assays. And for the time being, I think that pathology cannot be safely replaced by molecular assays. Tissue preparation is the key for accurate biomarkers evaluation, and advantages of combining the two approaches should be discussed. And I think that those tests are complementary, but one is not eliminating the other one. And these tools, a pathologist and a microscope, are still used and useful for the diagnosis of breast cancer. And I hope that, but you have to give us some time, not next year, but probably like EBCC 10, if Sanofi is still supporting this event, and I hope so, we will have EBCC 10, the return of pathology. I thank you for your attention.